So, okay, so we got Tosha and Jennifer Seider. Tosha owns Tosh.care, and we are partners at Boots and Bugs together.
Too much going on
And
for my
so we got a little
ADHD
background
brain.
information there.
Okay, I'll
And
go in
so
here.
Tosh.care, she specializes, she's like really
Oh, stop begging.
Oh, sorry. Hang on, guys. I'm trying to do the one.
Got him?
I think so.
Okay. Specializes in microscopes and also specializes in systems, protocols, introducing those into your practice. My name is Jennifer Seider. I am the sole owner of MicroLink DX. We do bacterial salivary testing. Tosha and I, we've known and we've been best friends for what, 20 years now, Tosha? And so yeah, it's really fun, and we're so glad that you've joined us. We've got a lot of information to share. Her and I are both, you know, in the trenches. We're both dental hygienists, and so we hear every day, you know, what you guys are wanting to hear. And so we're so passionate about dental hygiene and so supportive of dental hygienists and anyone on the team. So I'm really excited. On our next course in April, we've got a lot of team members, not just dental hygienists, but a lot of office teams, office managers, dental assistants, because we like to get everyone calibrated. So here we are. And I know we don't look as fancy. We're not all glammed up, but hey, we're good. Tasha's supposed to be rolling the slides.
I am. Sorry. I was making sure we're all muted for you.
That's okay. Learning objectives. As you can see, we've been friends for a long time. So what we're going to cover, and we're going to do this at a fast pace, and we're going to make it fun. And feel free to, of course, ask any questions later. So we just want to make a little bit of a change and really get you inspired. You know, and maybe tomorrow you have off, but come Monday, really get you inspired. So what is the biggest missed opportunity in perio treatment, and how does bioanalysis, salivary testing, how they're game changers? What can it really do to really amp up your practice? And then a real look at some microscope samples. Tasha's got all kinds of microscope samples, and they're really exciting to see. You know, I can say that to y'all because we're amongst each other. If you show anyone else a microscope slide, they're like, oh, is that in my mouth? Yeah, that is. And then also some fun verbal skills, some really simple verbal skills that we can get the patients to say yes. Especially those patients, Tosha and I, we really we're really passionate about those 6-month prophy patients that are not prophies that, you know, we, you know, traditionally thought everybody was bleeding. So how do we get those patients to convert and make them to say yes into perio cases? And then also patient acceptance without feeling too pushy and without feeling too salesy. So yeah, so all these slides are from Boots, Bugs, and Biofilm 2025. If you want anything, if you want any information, just send us an email. But we just want to let you know that. So just before we get started, in case you may have to get the kid out of the bed or refill your wine, don't forget you are invited to Nashville, Tennessee. So this is your formal invite. We do cap the registration. We don't want a whole lot of people there because we want to make sure it's impactful. And that way, for sure, on Monday morning, this is what we're so passionate about. You come to us on Thursday or Friday and Saturday till noon, and that Monday morning you change something. You don't want to go to a CE course and you learn a lot of information and do nothing with it. It's great, but you want to make a difference in your patients' lives. And so as dental professionals that we are, we can do that. And so we're super passionate about it. So here's your formal invite. Bleeding gum tissues, we go into that. We go into oral systemic coding, salivary testing, hands-on happy hour. Of course, that's the best part. But it's also fun, you know. And this is why I tell Tosha is it's okay to have fun and talk about periodontal infections and bacteria and oral systemic. We can do that. So on the oral systemic, you know, that can kind of I don't know, it can get kind of hard to listen to, my opinion. So I feel like that it's we give you just the bird's eye view and any new studies out there. So that's good to know. Okay, so we hope you join us. Yeah,
all right.
Go for it, Tosha.
We're going to get right into those learning objectives because we want to cruise through this at a great pace, but then also have plenty of time for questions that you guys have. So what is the biggest missed opportunity when it comes to periodontal treatment? And the most important thing, how in the world do we fix it? So I really feel, Jen and I feel like it's really thinking that periodontal disease is caused by an unclean mouth rather than a bacterial infection that requires ongoing maintenance and not just more cleaning and more tools to give that patient. So what is the fix? It's really our understanding that periodontal disease has involved a lot, and it's not just about a clean mouth, but really controlling a bacterial infection. And that is why continuing education matters. It's why all of us have so many required CEs that we have to take. We really, to keep up, we must invest in the right continuing education that stays up to date with the science, so we can accurately identify disease and treat it effectively to hopefully arrest periodontal disease, stop that infection in its tracks. Because really, when science evolves, our protocols should too. But as we know, it's not only about science. It's really about our ability to communicate what's new with our patients so that they understand that clean doesn't necessarily equal healthy. Because if we're being honest with ourselves, many of our patients, their mouths that we see haven't changed in a long time. But what ends up happening is that what we see is in their mouth, our understanding of that bleeding, it does change. And then we now need to communicate clearly that, yes, while you've been coming to me and we've been talking about bleeding, what are we going to do differently? So really having a clear calibrated path forward is key. So it's always easier when the entire team is on the same page with the way that we diagnose a problem, the way that we talk about it, the way that we treat the overall patient. So what Jennifer and I are trying to do tonight is to really answer these key questions that we would love for you guys to ask your patient or ask your teammates, tomorrow morning or Monday morning if you have, the Friday, the dental holiday of Friday. So how will you explain the problem to your patient? What will you do differently with their treatment come next week than you did maybe today? What protocols will you use to really get that patient healthy and not just cleaner? And of course, all of us need to know, how do we bill it? How do we do it? And we know that if we take a team approach to this, it's much easier. So what Jen and I are all about is having the right protocols in place to not just achieve clean, but achieve healthy, arrested infections. And so that means that we have to in order to create precision periodontal protocols, we have to understand what's truly driving the disease in the first place, which we now know is a bacterial imbalance. The host immune response is actually what's fueling the inflammation and the overall destruction of the gum tissue. So when we pinpoint the root cause, no pun intended, we can really make the right interventions, because we know that we can clean somebody's mouth, but so many of us have those patients that have immaculate home care. They come in regularly, they do all the right things, but their gum tissue still bleed. So Jennifer's going to go into some of those specific pathogens that cause periodontal disease that live inside the gum tissue and not on top of it. So Jennifer, take it away.
You always give me like the science part,
You keep
Okay.
the science fun.
It's fun. So traditionally, research is finding that it's not periodontal disease that causes systemic disease. So it's not the periodontal disease, it's the pathogens, the bugs, microbes, pathogens that cause periodontal disease that also contribute to systemic disease. So it's an infection. So periodontal disease is an infection. So I like to use the word periodontal infection. Because that's what it is. It's too much of a bad bacteria. That's what an infection is. Doesn't matter if it's in your tonsils, on your toe, where it is in your mouth, it's an infection. It's too much of a bad bacteria. So just to calibrate just a little bit, we know there's 500 to 700 different types of bacteria, bugs in the mouth. There's 11 that are linked to periodontal infections. So that being said, just remember that the amount of gum tissue, can y'all see my forearm? Yeah, my white as it goes forearm. The amount of gum tissue in your mouth is what is on your forearm. So if your entire forearm is bleeding and infected, you would go to the doctor. And even worse, if it was eating away at the bone, it's a big problem. Periodontal infections is a serious problem. It's eating away at the bone. That's an infection. So we really need to find out how bad this infection is. What is causing this infection? So go back just one for me here, babe.
Apologies.
You're fine. So I love this slide, and I use this slide a lot, looking at an ulcerated gum tissue. So I like to use, because I do have a little, well, she's not little. I say little, she's 13, about as tall as I am. But You know how when you were to fall down and skin your knees and your mama would say, be careful, you don't want to get an infection. Let's get a little Band-Aid on that. Let's get, some Neosporin because you have an open wound. Well, just think about that open wound in your mouth. So that is the inside of an ulcerated pocket and how the bacteria can make their way systemically. So we know there's 56 diseases linked to periodontal infections. So we really need to find out what is that root cause of the infection. Okay, go for it, Tasha. There we go. Okay, so like I said, 5 to 700 different types of bugs, bacteria, but there's 11. So microblink we do, and if you do bacterial testing, great. That's what you want to do. You want to do more diagnostics because we want to really find out how bad this infection is. It gives us one more tool to determine how bad the infection is, so we know how aggressively to treat it. We don't want to treat the patient the same way, no matter how bad the infection is. No other line in medicine do they treat the infection. They always do some sort of a diagnostics. They don't treat it the same no matter how bad it is. They have to do some sort of a diagnostics. We've got to use all of our tools to determine that. So just to calibrate a little bit, can you see my mouse? I don't know if you can, but that types of bacteria, that of course is on our website. So you got our scaling and root planing resistant. You got your tissue invasive bugs, meaning they're actually living in the tissue. And then you got your intermediate bugs. So I think you're going to talk about this too a little bit, like your grass fire pathogens. So those are the pathogens. When you do a bacterial test, you're like, okay, good. We can treat this. We're good to go. So yeah, you definitely want to know, how bad this infection is. So if you were to culture, look under a microscope, these 11 bugs, pathogens, microbes, whatever you want to call them, here's what they would look like. So there's some crazy little critters in there. And the thing about this infection, it doesn't just stay in the mouth. It's also communicable. I've been doing bacterial testing for 20 years. I know I don't look it, but I'm kidding. I'm doing this for 20 years. So we see a lot of reports that are from spouse to spouse to a parent to a child. So we definitely know this infection is contagious. It's an infection in the mouth, so it's definitely contagious. So here's what these little critters look like. They're not real cute. Wait till you see some of the ones that Tasha's fixing to show you on the microscope. So we got to know what we're dealing with if we're going to fight this infection. We just don't want to treat everybody the same. So why is biofilm analysis and salivary testing game changer? So how is it going to change what you're already doing? We get this question all the time. So what is it going to change? So it's going to determine how aggressively, beyond scaling and root planing, do you need to treat this patient? How sick is this patient? So do we need to do a systemic antibiotic? Of course, we always want to be careful with a systemic antibiotic. We don't want to throw everybody on a systemic antibiotic. But if we do, if this patient is sick, because unfortunately, most folks that have periodontal infections are not the stellar health. A lot of times, most of the times, they have something else going on, diabetes, heart disease. They've got something else going on. So sometimes they do need a little boost. So sometimes we want to do a systemic antibiotic and we want to know exactly what antibiotic to put them on. We don't want to necessarily put them on a broad spectrum antibiotic. We want to culture it, find out how bad the infection is, what it is, and put them on a systemic antibiotic. Do they need perio protect trace? Do they need laser? And then also, how frequent to set up follow-up appointments? Is this patient good for 6 months? Do they need to come back in 3 months? Where are we at with that patient? How soon do they need to come back? Do more family members need to be tested? So if you've got a patient that keeps getting this infection again, you do scaling and root planing, you haven't come back in 6 months, and you're like, we're better, but we're still not there, and you just fighting with this patient with unhealthy gum tissues, you may need to treat more family members. Hey, let me check. It's kind of like I always say, like, this is kind of, I guess it's kind of strep throat season, but like, when folks have several children, one kid has strep throat, you're like, treat them all. I mean, they're all gonna get strep throat. So maybe more family members need to be treated. And then eliminate active infection prior to implant placement. You don't want to place an implant into a bed of infection. do some sort of testing before you place an implant. If you've got a patient that's got an implant and you're like, yeah, we've got some problems here, do a culture, and then help eliminate risk for surgical complications. So those patients that are maybe going in for hip and knee replacement, and the orthopedic surgeon sends you a clean bill of health. Hey, are we good to go? They're not necessarily looking for decay. They're really looking for infection. So those are folks that it's a game changer on those patients.
All right, back to me, friends. So what does this all mean for our patients every single day? I think a big question is, that I get a lot is, what does periodontal disease actually look like? Because as we know, it presents so differently. And if every periodontal disease patient presented like this in our practices, I do think that our lives would be so much easier, because many teams think that they're effectively managing periodontal disease, but traditional diagnostic parameters are actually designed to look for the symptoms of destruction, when the disease has already set in, when bacteria is already in the bloodstream. We've all seen the largest study that was done to date that stated that by age 30, half of our patients had already lost 15 to 30% of the bone that supports their teeth due to gum disease. By age 65, 70% of our patients had lost 40% or more of their jawbone due to gum disease. That study didn't even look at gingivitis, which always is a precursor to periodontal disease. And that is the biggest problem there, is that we're not able to always catch these infections at their earliest stages. Why is that, do I ask? Well, I personally think it has a lot to do with mouths that look like this. In our brains, and definitely ingrained in my brain, used to be that this is what periodontal disease looked like. A red inflamed mouth, red rolled margins, in a patient that maybe they didn't care about their gum tissue health. They didn't get after it with the floss ever. They brush a little bit, but they're just not doing that great of a job. But the truth really is that the patients that have periodontal disease and the studies that have been done, they're on patients that are coming to our practices. And so many of their mouths look like this. They don't look that bad. They maybe don't look perfect, but they're not looking like, ooh, that person really needs to get after it with their toothbrush. They look like, their mouth's a little bit red, the gum tissue's a little bit swollen or abraded. But what all of these patients here have in common is their gums bleed like crazy. And we see bleeding all the time in our operatories. I mean, I used to think in my early days that everybody bled. Just because somebody didn't bleed a lot didn't mean they didn't bleed a little bit. And so I started to think that, well, maybe light bleeding is normal bleeding. And once a patient gets more bleeding, then that's actually when there's a problem. And really, the doctors aren't off the hook here either, because unfortunately, they see it too during restorative. And how easy or fast do you think restorations are when the gums are bleeding like this? Not the best way to achieve long-lasting dentistry. What we know is that so much has changed in our understanding of periodontal disease. What causes it? What are the best practices for treating it? Because it's no longer standardized scaling and root planing. Because we now know that there are bacteria that are scaling and root planing resistant, because they have a special protective jacket around themselves that's resistant to all of those things. We can clean and we can be the best clinician out there, but we can't get rid of infection like that. Science has evolved so fast, and science always evolves faster than a college curriculum ever can. So we need to rethink our understanding. 2 decades ago, when I graduated as a dental hygienist with blonde hair, I promise you that the knowledge between my ears was far different than that blonde-headed me. So radically different. What I really feel that we need to do is help our patients bridge the gap between what they used to think caused periodontal disease and what causes it now. But really, what's even more important than that is we need to bridge the gap for ourselves. We need to be able to educate our patients on what has changed and why this is different, and why now, after 20 years of us treating them with a prophy or with a perio maintenance for 10 years and their gums are bleeding, why do we need to do something different? And so much of this is because traditional diagnostic parameters, again, they just look for the reactions to the disease. By the time we see bleeding on probing, by the time we see radiographic bone loss, The bacteria is in the bloodstream. The systemic ramifications are already happening. But the tricky part for us is that we don't see that in our clinical chairs. We're not seeing the heart attack and stroke caused by the bleeding gums. So what Jennifer and my goal is really to not get rid of traditional diagnostic parameters. They're needed, but to just add those objective diagnostic parameters. The same thing that physicians do when we go in for, we think we have strep throat. We take our kid in, they go like, oh, let's take a culture of your throat. Let's find out, do you have strep throat? And so when we can look at a microscope slide and we go, oh my gosh, there's certain bacteria that are not part of your good guys. And from there, it's a much easier conversation to, I don't know what you came in contact with, so let's take a lab test to find out what's going on in there. It takes hardly any time at all. So microscopy has been around since the 80s. It really didn't catch wind until more recently. It's gained a lot more popularity recently simply because it's pretty easy to take a slide now. Takes just 30 seconds, another couple minutes to show your patient, and they're looking at you going, what are you going to do about it? And so Dr. Paul Keyes is really the father of all of microscopy. And what he noted in 1982 when he started using a microscope on all of his patients is he stated that it soon became apparent that there were striking differences between health and disease and the prevalence of white blood cells, types of organization, types of microorganisms, their patterns of organization or behavior. And although microorganisms could only be identified morphologically, I decided that all disease-associated bacteria would be considered risk factors and therapeutic targets. I know my videos aren't playing very well here. Sometimes Zoom gets a little slow, but on the left-hand side of the column, you guys can see all kinds of creepy crawlers. Those little creepy crawlers are what MicroBlink DX is testing for. So we know that certain shapes are not part of your good bacteria, but we don't know what they are without a lab test. So the conversation with a patient when we see those inflamed gum tissue can change when we start to talk more about the bacteria. And so for us, whether or not you have a microscope isn't necessarily the important part. It's for us to know, if I see bleeding, these creepy crawlers are living in their mouth. What can we do about it? Find out what they are. On the right-hand column where you see bacterial balance, those images look almost like a still image. It looks like I just took a picture of the screen. There's not a whole lot going on. That is homeostasis. That is where the bacteria is totally in balance. When we see patients that have any amount of bleeding, it's an immediate indicator that they have chronic inflammation. Because what the body is doing whenever there's biofilm and bacteria hanging out around the gums, the body is really intelligent. And so it picks up on that right away and it goes, ew, we need to get that out of there. So the first thing that the body does is it elicits an acute inflammatory response. What does that do? What does that mean? It means that the body is releasing lots and lots of white blood cells into the gums. And those white blood cells have a superpower. They're like an antimicrobial. So they're trying to disinfect the gums. But these bacteria, especially these scaling and root planing resistant bacteria, the red complex that Jen talked about, those bacteria have a superpower of this protective matrix material around themselves. So they're resistant to being cleaned away. So the body goes, okay, release more and more and more white blood cells. Well, before you know it, this tight-knit gum tissue is no longer tight-knit gum tissue. It's swollen. And just like a knit blanket, swollen gum tissue is leaky and permeable. So if that patient has periodontal disease causing bacteria in their mouth, they immediately enter the bloodstream. So if you see bleeding in your operatory, whether it's for a restorative class 2 composite or a prophy, if that patient has bacteria in their mouth, it's getting immediately into their bloodstream. And that's that oral systemic connection. So think chronic inflammation whenever you see bleeding. During a routine prophy, routine perio maintenance, if we see inflammation, the next thing we can do, if we had a microscope, is take a slide. But you don't need a slide. You don't necessarily need a microscope because testing is really easy. MicroBlink DX can send you tests. You can just take a test chair side. And the conversation just pivots, which I'm going to tell you about here in just a moment. So what I want you guys to think about is when I see inflammation and bleeding, that's the first indicator something has changed. The body is not fighting off this bacteria, because if it was, we wouldn't see bleeding. So if you guys are anything like me, in school, you learned a specific set of verbal skills and scripts. And those scripts might have gone something like this. Mr. Patient, I'm going to check your gums with this ruler, and I'd show him my probe. 1 to 3 millimeter pockets is normal, but healthy gums don't bleed. Oh my gosh, Jennifer, you have 7 5 millimeter pockets, 10 4 millimeter pockets, 18 bleeding points, even some radiographic bone loss and calculus. And Jennifer might look at me like, I don't even know what math equation you just gave me, but dude, none of those words sounded anything like infection. So why would she not turn to me and say, okay, are you going to clean my teeth today? And then most of us by this conversation, I mean, we've invested like 10 plus minutes into this conversation. And sometimes we've turned our patient into like a bobblehead and they're like, and we're thinking like, yeah, they're tracking with me. And then we present this treatment that's like $1,500 and they're like, I don't even know why I would need that. Like you were just telling me about some numbers and I don't get it. And so there's a big disconnect there. So my feeling is that nobody actually wants to be probed. So let's consider not saying the word probe. And so we could say something like this that will get our patient's attention. Mrs. Patient, I'm going to evaluate your gum health as we now understand the healthier your mouth is, the healthier the rest of your body. If I see anything that could cause you harm, I'll let you know. Immediately that changes the conversation and the thoughts in your patient's mind. They're probably thinking like, oh, okay. And we don't even need them to understand what we're saying. But what we do need is their attention. Because all of us, when we drove to work today, we didn't think about how we got there. Our brain was just autopilot to how we got there. Our patients, when they sit in our chairs, are autopilot thinking they're going to get their teeth cleaned. So if we don't snap them out of it, we're not going to get their attention. So we have to start talking differently and explaining this entire process different so that we can have this back and forth conversation.
Do I have a second?
Of course.
Okay. Can I tell the story? And this is totally off script. I'm so sorry.
I love it. Go for it. Go for it.
So I want to tell Marlon's story about him. Okay. So my husband, I've been doing bacterial testing for 20 years. He knows all about, he's a retired firefighter, 55 years old. You've heard this story before.
I love this story.
I love this story. Actually, Tosha was his dental hygienist. So anyways, so
not at this point, not during this point, not at this point. At this appointment.
So he knows all about the infection. He knows all about the bacteria and all the things. Anyways, he's retired. So, and he's not home. He's with Kennedy with her volleyball. Okay. So I'm sitting here at my desk. This is less than a year ago. He storms in the office and he's at his dental hygienist and he goes, she did some sort of plug in my teeth in the back. And mind you, we're in the South. So, he's from Texas and we're in Tennessee now. So we've got this accent. And I said, oh, did you have pocketing? He goes, well, you think? She went in there and she stabbed me with this stick. And mind you, I'm a dental hygienist. So, and we talk about this. He knows all about this. And he goes, she stabbed me with that stick. Well, yeah, of course I've got pocketing the way she was stabbing me. And I know his dental hygienist. She's sweet as can be because we all are. I mean, we all are. We're good people. And so he had a 5 millimeter pocket. So she placed a little arrested in there. And he was just funny because so she didn't explain to him that, everything about it. Of course he knows, but that's what the patients get. That's what they think. They, us as dental professionals, we're not used to having someone like, scraping around with a probe, like you say probe, with a notch metal stick. It is kind of scratchy feeling, I'm sure, if you've got a little bit of inflammation. And I use the word little bit. Tasha don't like when I say a little bit, when you have inflammation, right, Tasha?
That's right. That's right.
Yeah. So I say a little bit. Tasha says don't say a little bit, but you know what I mean. So we have to think about that patients really don't get it when they're upside down. They come in for their prophy and we sit there and we probe them and we try to give them a crash course in dental anatomy, because that's what we have to do as dental hygienists. Is we have to give them a crash course in pockets, and then their gum tissues are bleeding and it hurts, and we're like, oh,
it didn't hurt until you poked it, Jen.
Yeah, probed. I like the probe.
Exactly.
Anyways, that's my poor husband's stories. And he knows I know this story and I tell it. He doesn't know I'm telling it to y'all, but it's okay because he's the one that he knows better. He knows better. Go ahead.
But
Sorry.
it's one of those things that there is a large disconnect. And I think that so many of us, I mean, we see bleeding so often that it can be difficult to express it differently. And I mean, shortly after your husband had a scenario like that, my husband did too.
Oh, yeah, that's right. He did,
And
didn't he? I forgot
he's
about
an
that.
international pilot, so who knows what he came in contact with. And so, but when he came back home, he was like, I don't want to see that hygienist again. She was rough. I immediately thought, how swollen are your gums? If you think that the hygienist was rough, and I too know these women, and they're fabulous, and they're not rough.
amazing.
But I thought, well, it sounds like somebody has gingivitis. And so patients just don't always know what we're doing in there.
Yeah.
So
That's
when
why
we
I
do
do like your microscope. That's one of the things I love about using when my customers use a microscope is it's just simple and it's easy and it takes that crash course into just simple.
Yeah,
It
it's
literally
the
takes 30
conversation of
seconds.
I'm seeing a
Yeah.
change. Let's take a look at the microscope and see what's going on in there versus having to juggle around with it, especially if a patient's been a patient of the practice for a really long time. It's so much easier to explain. We got the microscope because we had patients that had bleeding with such great home care, and we wanted to just make sure we weren't missing something. And the patient goes, oh, wow, my dentist is like really high level here. And it makes it so much easier. But I know that it's not always feasible for everybody. But I will say, like, verbal skills and scripts are so incredible when we can use them in the right way. And it's important to speak to our patients in ways that they can understand. So what I have said to my patients for eons is, I'm seeing a change in your gums today. You have redness, inflammation, and even bleeding. Our patients don't know that not everyone, that a lot of people have bleeding. So really what we want is to ensure that our patients know that like bleeding is not normal. And so this definitely appears to be a gum infection caused by bacteria. Think of these bacteria like termites in the foundation of a house. They live deep inside your gum tissue, not just on top of it, which is why your great home care, coming in regularly, all the things, why that wasn't effective. So we want our patients to know it's not your fault. You just came in contact with some bad bugs and your mouth got sick. You can say bad bacteria. You can say periodontal disease causing bacteria, however you want to say it. You know your patient base. But we want them to understand, like, I'm seeing a change in there today. And so what if it's the patient that you have been talking about bleeding gums? Because this tends to be what more of my clients talk about. They're like, well, but Tosha, we've been talking about bleeding for like ever. So how is it different now? And I say, you know what? That's okay if we've been talking about bleeding for a long time because now we know something different. So we're going to educate our patient different. So Jennifer, I'm noticing persistent bleeding during your cleanings, which is a sign of a bacterial infection inside your gums. Since you have great home care, you stay on top of your cleanings, this tells me that something's happening below the surface that needs to be addressed. So we just double down on, yeah, I know there's been bleeding, but now we know something different. And now I know something different needs to change. And we can simply explain that to the patient that because I know something different, so I need to do something different. And the truth is that science has evolved so much. So it would be crazy not for our periodontal protocols not to evolve. I mean, we would never want to go to a physician that graduated in 1952 and still practices as though it was 1952. We would never want to go to them. We want to go to the people that are cutting edge and really going to help us to get healthy. But the way to do that is not to science them to death. It's to talk to them in layman's terms. So one of the biggest mistakes also that we make is the way that we communicate with our patients, which is why at Boots and Bugs, I tell Jennifer that I get to go over verbal skills and scripts.
Why?
And so many things can get lost in translation. And some of us in our personalities, and especially with hygiene, like, so it's a female dominated industry. And so we tend to be more of that caretaker to personalities. And so we don't want to scare the patient or make them feel bad. And so sometimes that's why we use some of this minimizing language. But when we tell a patient that you just have a little bit of bleeding, Jen, or it's just localized, it's just that lower left, or you have some bleeding points, some pockets. Well, those are in my pants. Probe depths. You need a deep cleaning and scaling. So when we talk to patients about a deep cleaning, the focus is on debris and not bacteria. When I've told my patient for years, like you have some pockets on the upper right. So when the patient comes in and they've been trained by me, like that they're like, oh God, Tasha's going to want to check those pockets on my upper right. I need to get away from that because if the patient has pockets on the upper right, while it's true, some people's infections present more localized than generalized, infections are rarely localized. So the takeaway is that people don't buy solutions to problems they don't perceive to have. So we definitely need to just make sure that our patients understand the gravity of what is actually going on in their mouths. So the words that we want to use instead would be the use of infection, bleeding versus bleeding points. You have a bacterial infection, jawbone loss versus pockets. Analogies that I absolutely love is you came in contact with some bad bugs and now you have an infection. Think of these bacteria like termites in the foundation of a house. The cleanings we've been doing is like a routine car wash. What you now need is the full detail, really spending time getting in the nooks and crannies, places we just can't reach with a traditional cleaning. And so when we label the type of cleaning that a patient needs as a medicated cleaning, we need to use medicine, they're more inclined to understand what they actually need. And so the key takeaways are that periodontal disease isn't about a cleaning, it's about a chronic bacterial infection. Science evolves, so we must evolve. A clear and calibrated team is so much easier to make this happen. And if we want to get our patients to the yes, we need to communicate in terminology that they actually understand. Because when we shift from routine cleanings and we pivot to targeted treatment, we can arrest the infection. So educate, communicate, and treat with precision versus just a one size fits all guess. Anything you'd like to add, Jen, before we
I
jump
love it.
into a little bit more and then some Q&A?
Well, yeah, I mean, you know how passionate I'm about this. My thing is, like I said before, as dental hygienist, and I don't know if I know we've got a few dentists, but you know, we're the only ones that treat this infection. So it's our disease, and we've got to treat it as dental hygienist. And I know dentists, you will support us for that. But we can't just let folks running around with an infection in their mouth that they're passing it to person. So we've got to treat it. We've got to be aggressive. So yeah. So thank you guys. This has been fun. I hope you've all had fun. It's not, I mean, isn't it fun talking about bacteria and infection on a Thursday night? So stay in touch
I mean,
with us.
they have to want to. I mean, they're here with us. So
I
cute.
know.
We're all perfect nerds together.
We are. We
I'm a
are.
proud nerd.
I know it. I know it. Yeah, I love it.
Oh.
So, yeah. So there was a QR code. There it is. Stay in touch with us. Is that our email or website, Tasha? I can't remember. It don't matter.
I don't know.
It's all
Scan it
connected.
and you'll
Yeah,
find us.
you'll find us and stay in touch. And so, like I said, you're of course invited to Boots and Bugs. I call it the ultimate Perio party. So it's a back and forth type of thing, as you just kind of got a taste of. But we're so passionate about treating this periodontal infection that you know, we definitely want to. You can feel the vibe from us. And so yeah, I don't know if you're local or not, but Nashville, Tennessee. Everyone wants to go to Nashville. I don't know if you know, it's really a good time.
It is.
And it is so fun. And so it's April 4th and 5th. We have a few spots open. We encourage team members to go. We did you post our video? Did
No,
you post?
we're gonna share a
Yeah,
quick little video with you guys, and then we're gonna open it up to Q&A. This video is
give
just
it
about like, I don't know, 40 seconds maybe.
19.8.
19.8. What?
I did that. I think it's 19.8.
Oh,
See, I'm technical, Tasha.
you are. We're gonna share this quick video, and then we're gonna open it up to Q&A. So stay with us, friends.
You know, a lot of us go to continuing education events and then we go to the office on Monday and nothing changes. This is different because they're tailoring it towards the business admin team, the hygiene team, the doctor team, the assistant team. So there's cohesion when we go back on Monday so we can implement it.
So just a quick little tidbit. What else do you want to share with us, Jen?
Yeah, so what I really like is with Boots and Bugs, and this is our Boots and Bugs is our side gig. I mean, we do this because we love treating this infection, and we want to empower other hygienists and other offices to do the same. And so we've got so many folks that have come back year after year that we've developed a gold level. And so what that means is when you come back a second time, like I said, we've got several, you get a magazine cover and you actually get an entire magazine. Thanks to Tasha. That was your idea on the total magazine. Mine was the cover. Yours was the total magazine. Total magazine. And then you also get a nice little infographics and a gold sweatshirt. So yeah, it's fun. It's for the entire office. And any questions?
Yeah.
Let's-
So how do you, oh, I see a couple in the chat. So how about, if people want to just ask a question,
Yeah.
maybe like the hand raising emoji, is that like, or, just pop on your camera real quick.
Steve Lehman, are you on here, my friend?
I'm going to answer a couple questions in the chat. So which probe do you prefer, metal or plastic? For me, it's personal preference. I can't handle myself a plastic probe, to be honest with you. I've got to have the metal one. But honestly, just probe charting is probe charting. And so, it's like if somebody asks me, Tasha, what's your favorite toothbrush? And I say, the one that your patient's going to use. Statistics show absolutely that mechanical toothbrushes are superior. But if my patient's not going to use it, then I'm not going to die on that hill. How do you treat amoebas? So amoebas are interesting because they actually can't survive in a dysbiotic biofilm. So if you treat their periodontal disease and their periodontal infection, typically they go away on their own and you don't need supplemental treatment for them. More questions, you guys can put them in the chat or you can unmute yourselves and holler at us.
Yeah.
Otherwise, we're just going to have to,
Uh-oh.
Oh, who's got something?
We said to start those patients. Okay. Yeah. So how do we set up an introduction? So yeah, so if you go to our website, let me tap it in here. I didn't think about that. About that. I just type in my cell phone number. I don't have any plans the rest of the evening, so just text me. How about that? Is that okay?
Great. I'll put mine in there too.
Yeah. Oh, I have a phase contrast microscope.
I have a phase contrast microscope. Can you tell me when there are spirochetes? So every microscope slide. So the question is about what are you seeing on the microscope? And I compare, so there's 3 different types of slides overall. So we have low risk slides that are going to have coxide non-motile rods. So they're going to look kind of boring like the one slide that I showed. And then we have a moderate risk category. So moderate risk is going to be spinning rods, which are these tiny little guys that kind of twirl all over the place. They are like, I consider them gymnasts, like think Simone Biles, always flipping and turning around. They can look very similar to a coxide, but they're not going to just be floating like a lazy river. But when we have a high risk slide, we can have gliding rods, we can have spirochetes, we can have lots of white blood cells, all different kinds of looks to it. We can have a few spirochetes, we can have a gajillion spirochetes. They're all high risk. So gliding rods are as pathogenic as a spirochete, although they don't look that ominous. So all of them still get classified in the high risk category. Okay. I hope that answers the question.
Yeah, so then we have any verbiage regarding a patient who is against taking antibiotics.
Absolutely. So yeah, so with patients, I work with a ton of biological practices, and most of those patients are not going to take a systemic antibiotic no matter what. And so my recommendation is to test before and to test after so that if you've made some significant progress. I've had some patients that are younger and healthier that have been able to tackle all the pathogens on their result reports without systemic antibiotics. The key is that they are disrupting and disorganizing their biofilm every day, penetrating the biofilm wall. So in the practice, when we're doing our gum tissue therapy or antimicrobial therapy, the patient cannot simply be brushing and flossing at home. they have to use a water flosser, they have to use Perio protect trays, they have to do something to penetrate the biofilm wall, because brushing and flossing with aggressive pathogens, especially those resistant ones, you're smearing it around. So they could be doing a great job, but they're only smearing it around. They're not penetrating the biofilm wall. So that's the tricky part of that. So what I would share with those patients is we can try a lot of different things. We can try a lot of different types of antimicrobials. Maybe they have ozone at home. That's going to be really great. But if you're taking a before and after test and they're still not getting better, then sometimes it's, you know, gut health and all these other things. But then you just simply put it back to the patient and you say, we've been doing everything that we can do for you here. This is what you've been able to do for yourself at home. How is your overall systemic health? Where do you want to go from here? Just like somebody with, you know, something terrible like cancer and they go through chemotherapy, it's fighting fire with fire. It's not always the best, but sometimes we need to weed, feed, seed. So that would be my soapbox on that.
Okay. Well, there was one question.
So you mentioned that patients that have good home care and still have bleeding need treatment. What about patients that have poor home care? So my feeling on patients that have great home care or awful home care is that they still need treatment. Here's my rationale behind that. If I have a patient that just for whatever reason cannot get on the home care bandwagon, I'm still going to recommend in-office therapy because I know that in-office therapy can get down the overall pathogen load. So like, let's say that the pathogen load is up here and to get to homeostasis is way down here. But if I can get it to here, I might get it low enough to where their immune system can help to at least keep it at bay to where less pathogens are getting into their bloodstream. And maybe then they won't die of Alzheimer's disease. Maybe then they won't develop, you know, diabetes or some of these other causative components from gum disease, because it's a two-directional relationship. And so I still believe in treating them and walking with them before you run. Any progress is still beneficial. So that's my opinion on it, is
Yep.
still to treat.
We've got a question on, I would love to have a microscope. Do you have one you recommend?
I do. My favorite microscope is this one back here. It's called a Modic Panthera. I love Axe microscopes. They're a small family-owned and operated company in Nashville, Tennessee. If you want to reach out, email me. I can share with you their information. I'll put my email in the chat.
Yeah. And
So
they do the
email-
record. You
email
do the
me and I can-
recording. Yeah, and they
And I'm recording
record,
too.
right?
Yep.
But I mean, they also record, right? You keep the patient file.
Oh, sorry. Yeah. So this
Is that how
microscope
we
right
keep
here,
all those?
yeah, it zooms in, it zooms out. I mean, the clarity is absolutely incredible. The ease of use is super easy. You can record pictures, you can record videos as long as you want. You just put them on like a little like micro SD card and you can get an SD card reader. I mean, microscopes now they're so easy to use compared to what Dr. Kai's used in the 80s, as we can imagine. You know, it's technology. They all
Yeah.
could.
So I have a little friend here, Chrissy. Hello. Over the years doing bacterial testing, it's been explained how important ultrasonics are for disrupting the biofilm to work with the antibiotics and the importance of multiple visits versus doing half mouth at a time. You heard that from me, but go ahead, tell your thoughts on that.
Yes, I mean, if you tell the bacteria like, hey guys, I'm going to clean the right side, do
Go
not
over there.
go over there. They're not going to. So what Jennifer and I teach at Boots and Bugs is how do you do full mouth treatment and get paid for it? Well, you can't submit 4 quadrants of SRP, but you can still disrupt and disorganize the biofilm, and there's some different ways to code that. But even if you don't code it as anything, run around with your ultrasonic in the entire mouth and give the patient a freebie on the other side. You're not trying to remove calculus, you're disrupting and disorganizing the biofilm wall. Because the important thing is that biofilm, if this was like the tooth surface, I don't care if it's a 2mm pocket or a 12mm pocket, biofilm is like this. It's got these finger-like projections. The nutrients flow through, they feed it. The bacteria lives inside, so you got to penetrate the biofilm wall. So if we're just brushing and flossing or ultrasonic on one side, you know, the other side is just going to contaminate over there. So the biofilm, when we're brushing and flossing or just scaling, We just falls away and just attaches someplace else. So full mouth treatment multiple times is absolutely key.
Yeah. Yeah. We've seen it time and time again, haven't we, Tasha? So what I say with biofilm, and this is my little way to explain biofilm, is you know how when you feed your dog over and over and over, you get that slime layer around around the bowl. That's biofilm. That slime layer that's sticky that you've got to get your Dawn soap out, wipe it down. And so we call it a purple complex. We don't test for it. We don't need to. It's not pathogenic, but it is that sticky layer, and it forms in 5.5 hours. So very quickly. So what I tell when I talk to dental hygiene students is, about lunchtime, as dental professionals, you know how we are about lunchtime. We feel that about 5 hours, we can feel that biofilm layer build up. My husband, the one that has the arrestin, he says, "You got your biofilm?"
I love it.
So
I love
so either you use GBT guided biofilm with EMS, use
I have,
whatever.
I have lots of clients.
Yeah,
Lots of clients that do. It's
Mhm.
it's certainly gained a lot in popularity. And what I will say is it's a great tool for our patients, but the best tool for our patients is home care.
Mhm.
It's really a dentist that I worked with for a while. She came up with this great thing, and she's like, it kind of encompasses everything that you already say. So for the best treatment, it's a 3-tier approach. So it's what we're going to do for them in the office. So you could have the best tools and technologies in the office. That's great. Or you could have basic stuff. You can still get patients better because it's a 3-tier approach. Tier number 2 is home care. What is the patient going to do for themselves at home to disrupt and disorganize the biofilm? And then tier number 3 is one that I never learned much about in school. And that is, what is your immune system going to do?
Mhm.
Do you have a patient that has Crohn's disease and rheumatoid arthritis? They're just full of inflammation. They're also taking an immunosuppressant drug. And so like, it's like a double whammy. They not only have inflammation, but they're also clobbering it with a medication that decreases their immune response. Well, they're, for one, going to be more susceptible to a gum infection, but for 2, it may be harder for them to get better. So we need to treat those patients extra aggressively, treat them sooner than later, keep them on a short recall, because 2/3 of that equation was not what I did in the office. And there's also 365 days a year. If I see a patient 4 times a year, I mean, if they're just phoning it in at home, it's going to be harder to keep them healthy. I would still treat them, but I would tell them, hey, if you're not doing all the things I'm recommending you to do, it may be harder for you to stay healthy. That's part of why I love the microscope so much, is because whether you're a logical mind person or an emotional buyer, it makes sense. You see the stuff and you're like, ew, what is that? That's in my mouth. Or you see it and you're a logical thinker. You go, how did I get that? How do I get rid of it? What do I need to do?
Right.
So
Or they'll
it's
say,
just-
is
it
that
appeals.
in my mouth? Yeah. And so
Yeah.
everyone responds differently to infection. And Tasha and I, we've done this, we've talked about this how many times, to where her and I were pretty much the same age, and we kind of live the same lifestyle, but I've never had the flu, never had strep throat, never had anything. And Tasha can walk outside and sneeze. Like if it's blooming, you're right, Tasha.
With seasonal allergies, yeah.
Seasonal allergies.
I blame it on
We
growing up
all
in North
respond.
Dakota where it's frozen.
Yeah, we all respond differently, so anyways, does any other questions? Did y'all have
Well,
fun?
yeah,
Oh,
I think
Forrest,
Forrest has one.
go ahead.
We're a biologic practice, and we do ozone bacterial reduction and laser bacterial reduction. But yet we still get a fair amount of patients, not a lot, because they kind of seek us out for that. But the line is, what will insurance cover? So do you all have some verbiage for that statement?
I love those.
That is
comments.
informal, that's helpful, that doesn't scare them to death, and that they
Yep.
can understand.
Yeah, so I would say there's a couple approaches here. So my first one is that when it comes to periodontal treatment, I sell the treatment that they need in a package approach. So for gum tissue therapy, Forrest, the full office fee is $1,500. I estimate that your insurance savings is $500. That puts you at $1,000. Obviously, I'm making all these numbers up. When the patient says like, oh my gosh, that's all that my insurance covers, I say, you know what, I'm sorry, you do have a limited policy. Insurance typically doesn't cover much on these until the infection is very severe and has already necrosed a lot of the jawbone. And so when it comes to things like ozone, what I explain to the patient then is that insurance pays typically more on services than on products. And they look at ozone as more of a product. The great thing about ozone is it kills bacteria, fungi, and protozoa, but it supercharges your good bacteria. So this can really help you to get better, heal faster. But unfortunately, insurance isn't looking at that as part of the service. So kind of taking a couple different approaches to it is can be helpful.
Okay, thank you.
You're welcome.
Yeah. Anything
Now we're
else?
close to the top of the hour. We want to respect everyone's bedtimes.
Yeah, bedtimes. I heard, so Tasha, believe it or not, has a coon dog. Was he barking? Was
He
he
was.
out?
I was hoping you guys couldn't hear that.
I heard.
There's probably
You would
zero
think
barking.
I would have the coon dog. Tasha's got the coon dog. She's got a red bone coon dog. I've got a Doberman. And I heard him back there. It's a pup. She's got a pup, coon dog pup.
Yeah, yes. He's
And he
7 months
says,
old.
mm-mm.
He's a teenage crazy man.
He's like, what are you doing back there? So can we stay in touch with y'all? Can you put our slide back up for our phone numbers, Tasha,
yeah.
or something? And will you stay in touch with us all? I hope you all had a good
I
time.
don't, do we have our phone numbers on there?
I mean, surely we've got our email. I guess I didn't put it in there. Go
There we
back a little bit. Yeah.
There you go.
Yeah, that's our email. That comes to both of us.
Yeah.
We had a good time. I hope y'all did too. See, it is fun talking about bacteria. Y'all had a good time, right? So maybe we do this again. We just kind of decided, we started talking the other evening, and molecular iodine, Tasha. I know you've got a little bit of information on that real quick.
Oh, products. So like IO rinse, is that what we're talking about here? So molecular iodine is not. So yes, I like molecular iodine. IO rinse, I do have a lot of practices that want to use the IO rinse. If you have a microscope, what's really interesting to do is to take a patient that has a pathogenic biofilm and put it in that solution and determine if you want to use it. So if you have a very dysbiotic biofilm, some of the really great rinses that we have available to us are not strong enough to kill those bad bugs. And so, ozone, like you were mentioning, Forrest, is incredible. There's a lot of really great herbal rinses out there. When it comes to essential oils, we're talking about clove and peppermint oil and tea tree oil are some of the best. Some people use chlorhexidine. Some people think it's the worst thing ever. I'll try to remain neutral on it on this call. There's a lot of great things, but really, if a patient is using a water flosser at home and that stuttered stream with the pickpocket tip and they're aiming it up at their gums, that's going to penetrate the biofilm wall. So within the practice, sometimes what guides what you can use is what tool you actually have. So if you have a Cavitron and a dual select, they're only going to approve certain products. But if you have a piezo, again, like they may only approve certain products. So I don't want to tell you guys a medicament to use and it's not approved in your device. And then you're like, well, Tasha said that I could use this and now it clogged my machinery. So I give you permission to please email me that specific question so that I can better guide you. And I put my email in the chat earlier, but it's just TOSHA, Tasha at Tosh, TOSH.care, CARE. All right.
Are y'all good?
I think we're good.
Forrest, did you have fun?
Yeah, this was great. I'm the newest hygienist in our practice, and we use microscopes and things. And so I'm really soaking in anything I can to make sure I'm recognizing everything on the slide. We characterize, healthy cocci bacteria.
Baby, I'm done.
The moderate stuff, and then the pathogenic spirochetes and things like that. But seeing the slides, hearing you all talk, and really how to sell I'm using sell in a good way.
That's okay.
there.
We're good. We
Yeah.
gotcha.
To convince the patient that they need to take this treatment we're recommending. I love the ways to say it, and that really helps me.
Good.
Awesome. I love
That
it.
was great. That's why we wanted to do this, is maybe we can help somebody. So that's good. So
Awesome.
will you stay in touch with us? Go follow us on Instagram too.
Yeah, we have
we post a lot of fun little things, and maybe see us in Nashville. And if you come to Nashville, wear your boots. You might have special prizes. I love me some special
right.
prizes.
All right, y'all have a great evening.
Take care, y'all. Bye-bye.
Bye.
See you again. Take care.